So this is the review for 3320. Yep. I don't know where Jamie is.
Jamie's unwell today, so I'll be giving the...
Oh, okay. All right, I was looking for Jamie. So you're going to be giving his...
I'll be giving the neuro recap, yeah.
Oh, okay. All right. So, okay, I was just sort of thinking I better wait for Jamie. So.
Oh, no, sorry, yeah. He's unwell, yeah.
All right, good. Well, so I'll go first then, and then you do the next bit. All right. Yep. Okay, so this is just going to be a bit of a review on the last bit of 3320 of the lectures that I gave, and it was Jamie's, but it's now going to be given by Alex. So just really what we're just going to do is, I'm just going to, my part of it, I'm just going to highlight some of the key things from each of the lectures. It doesn't mean that these are the only things that will be examined in your exams, but these are probably the sort of the main important parts, or some of the main important parts, that will be included in the examination as well. So I'm just going to break it up into a few key slides on each of the different lectures. So just the lecture on autoimmune disease, I mean, at the end of the day, you've just got to go through what I've put at the beginning, and that will give you a good indication of what's going to be covered, for example, in the exam. Explain how disruption of self-tolerance leads to autoimmune disease. Describe the core features of rheumatoid arthritis. Briefly outline how rheumatoid arthritis develops and progresses. And understand the therapeutic goals and how we both maintain function and prevent pain in patients with rheumatoid arthritis. And the sort of drugs, the analgesics, for example, that we use, and some of the other key biologicals that we're using as well. And I suppose in particular, maybe to outline a few key disease-modifying drugs that we should be really paying attention to. These main ones are your methotrexate, or low-dose methotrexate, TNF-alpha antibodies, IL-6 therapies, and JAK inhibitors, etc. So these are really important that you know something about these, and at least some examples of some of these. So just remembering that autoimmune disease is self-attacking, so disruption of immune tolerance to self-tissues. I'm not going to go through all this because I've only got 20 minutes for my part, and I think I've got 4 minutes per lecture. So just to point out, though, that what it does involve, the cells it involves, B cells, T cells, etc. That it can be organ-specific, and these were some examples of thyroid gland, diabetes, and multiple sclerosis. But it can also be non-specific, and this is what we sort of mainly know or think of when we think of rheumatoid arthritis, being in the joints. But it can also cause problems with other diseases such as SLE, when you've got DNA, antibodies to DNA. So mechanism of immune self-tolerance. You've got your central tolerance, which is in your primary lymphoid tissues, and then you've got your peripheral tolerance, which is outside the primary lymphoid tissues. And you need to know a little bit about central tolerance and peripheral tolerance, and what cells are involved and how it presents. And then what is rheumatoid arthritis in itself? Now, a little bit about the disease. That we know it's a chronic destructive autoimmune disease. It's the commonest of all the autoimmune inflammatory arthritises. This is important. There's two types: there's seropositive and seronegative. So people look for rheumatoid factor in the serum, and that's a good indication of having rheumatoid arthritis. But you can be seronegative as well. It doesn't mean you haven't got rheumatoid arthritis. So you don't just look for one thing. There's lots of things you've got to be looking for. So this just talks about it. And also, not just rheumatoid factor, but also antibodies against citrulated peptides. So you get these anti-cyclic citrulated peptides as well. And then arthritis itself, it's polyarticular, means it's occurs in many different fingers, toes, etc. Many different joints, that's the word I was trying to think of. It's symmetrical, so you get it on both sides, doesn't just happen on one. And it can particularly affect mainly small joints in the hands and the feet, but it can over time affect large joints. And extra articular, meaning that it can also involve other things such as the heart, can cause fibrosis, can cause vasculitis, keratitis, etc. And what causes it? Well, specific causes, we don't know what actually is the main cause for it. We know it's associated with a number of different HLA and other gene types, but the cause is not exactly known. And we do know that genetic factors are really important, and that men are probably more affected than women. That women are more affected than men. And we know that there's environmental factors, and so we need to know some of those environmental factors that can lead on to it. So we know smoking, obesity, etc. is associated with it. Actually, I'm just going to skip through this. Early development of RA, how we get it. Well, maybe if you're susceptible, you have things, and I think the key here I'm trying to point out is that you can get this citrullination and generation of new epitopes, which are really important. So we need to understand the steps that are involved in getting RA, how it leads to cell activation, and then that leads to activation of your T cells, etc., and then B cells, and autoantibody production. And really importantly, at the end of it, we get a whole range of different cytokines that are being released. And these are the cytokines that many of the drugs target. And the main reason for this is that these are a point that we can actually interfere. And so another one, but some of the key ones that we interfere with are IL-6, TNF alpha is probably the most important two of them. And that we have disease-modifying anti-rheumatic drugs, or these DMARDs, and these have changed the outcomes of rheumatoid arthritis over the years. And this is sort of talking about the different things that the DMARDs target. Most importantly is the targeting of T cells as well. And in fact, a lot of the immunotherapies that are being used, particularly for any of these type of diseases, are all targeting either the T cell or targeting IL-2, interleukin-2, as the key mediator. Some do also target B cells as well. So this was just showing here that IL-6 and TNF alpha are the main ones that we target, and we have biologicals to both TNF alpha and IL-6 and to IL-6 receptors, and we also have targeted synthesis to the JAK inhibitors, okay, which is downstream signaling molecules. So it's really important that you just understand what sort of drugs and what sort of targets they work on. And methotrexate and leflunomide are two of the main key conventional synthetic types of DMARDs. So then in immunosuppression, we're basically talking about the key things again you need to know: how the immune system works, describe the role of T cells, describe the importance of IL-2. This is really important in this part because IL-2 is the target of most therapies. Outline why immunosuppressant therapy is actually needed, and describe in some detail the mechanisms of action. List the adverse effects of immunosuppressant classes, and explain how dangerous drug interactions arise with immunosuppressants. So why do we want to suppress it? I think the key thing here is there's lots of reasons. One of the main ones is because of organ transplantation. We can't transplant an organ into someone without suppressing the immune system. We also need to treat autoimmune diseases. That's the other why we need to suppress the immune response, because in autoimmune disease we have an overactive immune response. And treat some resistant inflammatory diseases which can't be treated by standard approaches. And I suppose the key here is that interleukin-2 and IL-2 receptor is usually the target for a lot of these. So IL-2 is a critical T cell cytokine. It's produced by activated T cells and it regulates T cell proliferation. It's an autocrine growth factor. That doesn't really matter so much, except that the number of components to the receptor complex, and that CD25 or IL-2 receptor alpha is often used as a biomarker. IL-2 signaling is very complicated, and the key here though is it is a stress again. It is the main target of immunosuppressant drugs. Okay, so this is a bit of a key. Most of the lectures I give, if I put it in bold, it's usually important. And then we were talking about some of the inhibitors. We talked about the calcineurin inhibitors. You'll need to know an example of some of the different types of inhibitors. cyclosporin, which is also known as cyclosporin spelled differently, and CSA, or tacrolimus. So you need to know about cyclosporin and tacrolimus as the calcineurin inhibitors and what calcineurin inhibitors are. They're effective drugs, target signaling pathways, and they block activation of IL-2 gene transcription. Again, I'm not going to go into detail. We've gone through that in the lecture, but it specifically targets a particular part of the pathway and blocks NFAT dephosphorylation. So know about calcineurin inhibitors. And then we've got your antiproliferatives, such as your antimetabolites and your mTOR inhibitors. Mycophenolate is a good one to know. I would know mycophenolate. What it is, again, I'm not going to go through it in detail, but it's one of the original drugs that we used. But it does have side effects. All of these drugs have side effects, and again, it's worth knowing some of the side effects. And these are some of them that are just outlined here, but as I said, we've done that. Azathioprine is another good one to know. This is basically a purine analog, and it takes the place of 6-mercaptopurine, and it can block DNA synthesis. So again, know a bit about azathioprine. And then these are the mTOR inhibitors, sirolimus, also known as rapamycin, and everolimus. Know something about these drugs. And again, I'm not going to go a great deal of depth about them now. We've already gone through all that, other than to say it's worth knowing something about them. And of course, glucocorticoids. Really important to know about glucocorticoids. Main ones being prednisolone, hydrocortisone, and dexamethasone, which are the most well-known ones. But also know something about immunodepleting antibodies. So this is the way of the world we're going into now. A lot of the different treatments are all trying to block things using antibodies, and they are good approaches. They have their problems with it as well. Both polyclonal, which is usually a mixture of antibodies antibodies against a mixture of different parts of a molecule. So it's actually raised not as a monoclonal. A monoclonal meaning it's very targeted and specific. And this is what I think I'm going down here. It's directed against very specific antigens, whereas the polyclonal is a bit more broad. And then often a polyclonal antibody is better because it interacts a lot more with a lot of more diversity on the protein of interest, whereas the monoclonal is very directed. And these are some examples. And again, it's worth knowing a couple of examples of the different ones. Rituximab is particularly important for looking at B cells. So this targets B cells. It's used for a lot of the B cell cancers, and it's also used as immunotherapy for other diseases too. So then tissue repair and fibrosis. Actually, we need to know about acute inflammation. We need to know how vascular response occurs. We need to know the difference in the outcome of tissue injury. We start off with injury. Where can we lead to? Does it lead to regeneration? Does it lead to repair and scarring? Does it lead to fibrosis? So we need to know the differences between tissue repair, regeneration, and fibrosis. Really important to know the difference between tissue repair, regeneration, and fibrosis. And what are the process of fibrogenesis? How do we get fibrosis? What are the key mediators? Transforming growth factor beta is really important to know about. There are others, but TGF-beta is the main key one. And then describe some antifibrotic therapies that we use. So, I suppose with the inflammation, you've got acute, chronic inflammation. Know the difference between acute, how you recognise it, chronic, what the difference is. Know clinical signs of acute inflammation: heat, pain, redness, and swelling. Rubella, dolor, choler, tumour. Know those. Loss of function, of course. Know some of the key components of the acute inflammation, such as the vascular response and the cellular response, and what happens, what controls it, what causes vasodilation, for example. What cellular mediators are important, really, really important. And know about histamine and serotonin. What do they do? Rapidly released from mast cells, etc. And they're very important in a number of things. and the main role, I suppose, histamine is a vasodilator. But initially causes constriction of large vessels, but it can then causes vasodilation of small vessels. And that's what we get, the vasodilation and that sort of typical wheel response that you see where you get edema as well. So know about that. And know, as I mentioned, the outcomes of acute inflammation. This is sort of about tissue repair as well. We can have it resolved and we can have it unresolved. Factors that influence the repair of injured tissues. Know the difference between labile, stabile, and permanent tissues. That's really important. Know how injured tissues can be repaired, or what happens in the repair process. You can get regeneration, you can get healing, or you can get fibrosis, and they each have their own characteristics, and you need to know those. And that's just using lung, because that's what I work on. I like lung. But effectively, if you think about fibrosis, which is another key area we talked about, it is an aberrant wound healing response. So here is basically just telling you that it's really important to know that regulation of healing and repair occurs through a number of different mechanisms, and particularly when you talk about intracellular signaling, occurred by autocrine, paracrine, and endocrine signaling, and know the difference between those. It's very important as well. Know about extracellular matrix. What is it? What does it do? We've got interstitial matrix, we've got basement membrane type matrix. What are the different types of matrices? What are the most important ones in wound healing? What can happen in fibrosis when they get too much of it? I think here just outline what the role of the ECM is. So although it provides a scaffold for cells, it can be involved in other things as well, and it can control other activities such as migration, proliferation, differentiation, apoptosis. So it's not just structural. There's different types of proteins which have all these different roles. Collagen, for example, is more structural, but some of the others, like the proteoglycans, etc., have lots of different roles. So know a little bit about extracellular matrix, different types, and what they do. Particularly how important they are in fibrosis, and which ones are important in fibrosis, which of course is your collagens predominantly, because they are the structural protein which causes the loss of tissue function. Know the difference between primary intention and secondary intention. Primary intention is is a clean cut where things heal by directly closing, whereas secondary intention is when you've got a bigger wound and it has to fill with granulation tissue. Know the difference. You do get granulation tissue with primary as well, but not as much as you do with secondary. So know the difference between primary and secondary. Know that myofibroblasts are really important for wound contraction. Without wound contraction, a large wound's never going to get smaller. So you need to have these myofibroblasts, really important cells. But in the case of fibrosis, they become the problem because they don't go away. They don't apoptose. And so you've got a lot of collagen, because as well as contraction, they also make a lot of collagen. And so these could be the problem cell as well as being important in tissue repair. Whoops, I'll just go back there. And again, know some of the things that can differentiate a fibroblast to a myofibroblast. I think it comes up later on. But know what key media is, such as transforming growth factor beta, which is really important. Stressing transforming growth factor beta. And there it is, THF beta, what it does. It's really important as a profibrotic mediator, promotes matrix synthesis, myofibroblast differentiation, etc. And it does these other things as well. But really, want you to know how it's a promotion of matrix synthesis, and it actually promotes transformation of fibroblasts and other cell types into myofibroblasts, such as epithelial cells can go on to go epithelial mesenchymal transition to become myofibroblasts. Fibrosis is the excessive deposition of matrix, and it's a major, or can be a major clinical problem depending on where it is. If it's in a major organ, that's going to impact on its function, then it's a big problem. But the key is that wound healing and fibrosis share many common themes. So really, fibrosis is just wound healing gone wrong. All the steps in wound healing are the same steps in fibrosis, just it doesn't stop. The stop signals are not there, and you just get this overproduction of matrix and excessive type healing, which type response, and end up with fibrosis. And it's really good to know this table to get an idea of what the difference between tissue repair and fibrosis is. Okay? So that sums up a lot of what you'll need to know. And then we talked a bit about pulmonary fibrosis. Just know what pulmonary fibrosis is and idiopathic pulmonary fibrosis. Know that idiopathic means we don't know. We just don't know what causes it, so it's idiopathic. And some of the characteristics of pulmonary fibrosis as the model for a lot of different organs. And then know some of the different therapies, particularly the current IPF therapy. And I'm talking about IPF, but in fact these are the only therapies really for most fibrotic conditions, particularly lung fibrotic conditions, are these nintedanib and pirfenidone. So know what they are, know how they work. Nintedanib is a tyrosine kinase inhibitor. Pirfenidone, we don't know how it works. We think it works through blocking TGF-beta. It may work through other ways as well. But, the propaganda out there is it works by blocking TGF-beta. So expensive, etc. Know some of the side effects of them. The fact that they're not effective in everybody means that we still need to find better treatments. And these are just some drugs. I don't expect you to know this, but know there are different types of drugs in clinical trial for fibrosis, and that they're basically attacking all of the key parts of the pathogenesis of fibrosis. And ones that maybe you take a little bit of attention to is senolytics. So they selectively induce death of senescent cells, cells that no longer are dividing. So old cells. So senolytics have been sort of put out there as a way of making us live longer, because we can attack dying cells and regenerate new ones. So it goes through a bit about cellular senescence. And the drugs that mainly are important, that most people are using out there, is dasatinib and quercetin as senolytic agents. So just know about them, know their name, remember them as an example. You don't know too much detail otherwise. And in immunotherapies, know a little bit about the fact that antibodies are being used to target different molecules, and here's some of the ones that they target. Again, you don't have to know all these, just be aware of them. And know that checkpoint inhibitors, which are being used for cancer, is also used starting to be used in fibrosis as well. And there's various others, CAR T-cell potential. These are more experimental, so I don't expect you to know them, just be aware of there are different types of therapies. And there are B-cell therapies as well being looked at as well. So I'm just in the last 2 or 3 minutes, I'm just going to give you some examples of the sort of questions you're going to have. For example, which of the following drugs are calcineurin inhibitors? So I've already talked about you need to know some calcineurin inhibitors. So have a look at those. Can anyone tell me which one it is? Dead silence. A. Good one. All right. So A, answer, cyclosporin and tacrolimus. Okay, which I showed you just a few minutes ago. Okay, which of the following are not pro-inflammatory cytokines? This might catch you. So you've heard about all these pro-inflammatory ones. Which of these is not pro-inflammatory?
B.
B? Correct. IL-10. It's anti-inflammatory. It's not pro-inflammatory. Patients being treated with TB. Caseating pulmonary granulomas are seen on microscopic examination of a lung biopsy. What is the usual outcome of a pulmonary granuloma after treatment?
We think it's D.
You're thinking right. D, scarring calcification. You're going to do well. Okay. And I think I've got one more, or maybe two. The role of collagen, what is it? I've talked about collagen. What is its main role?
D.
Correct, D. And it's not cosmetics. Let me just tell you now. This really gets my goat. I work on collagen, and you see all these skin creams, and they say collagen. We can put it on our face, and it gets absorbed in the skin. It is a giant molecule. There's no way collagen gets through the skin. All you're doing is putting on very, very expensive moisturizer. That's literally it. So that anything that says collagen can be absorbed under the skin by the skin. Oh, one more. Regeneration means.
E. No, it's B. Sorry, I think it's B.
B? Why is it not C?
Then it's C.
Stay with what you know. It's B. Replacement of tissue. But a new one of the same type. So if it's regeneration, it's got to be of the same type. It can't be of another type. All right, so there's just some examples. They're the sort of questions you're going to be asked for the multi-choice anyway. All right, I'll hand over.
Cheers. All right, good morning, everybody. Yeah, I apologize for Jamie, who's unable to make it. He's unwell, but given that I gave the full Neuro series last year, I think I'm okay to be able to cover some stuff today. So I'm kind of very similar. I will go over some of the kind of core concepts from each lecture slide, and we'll talk about some stuff that you might need to know. And if you have any questions at the end, let me know. I will say that in this recap, I'm not covering the lecture on dementia. So the one about dementia, the key thing of dementia is you need to really know what the drugs, how the drugs are acting, and what they're actually doing to actually treat, or what we think is treating dementia and Alzheimer's. And also in what instance you may not want to give some of those drugs. Okay. But anyway, we'll move on with the rest. So we'll start off with the start. So at the start, Jamie would have introduced you to the concept of neuropharmacology and kind of what's involved. And so does this table look familiar to you guys? Yeah. So Jamie would have described to you what are some of the major classes of drugs, right? And so you may want to know what are the targets of these drugs and give some examples of them. So for example, in terms of anxiolytics and sedatives, right? So you would need to be able to define what these kind of drugs are. So when we talked about anxiolytics and sedatives, you need to know that these are drugs that reduce anxiety and they cause sleep. And you want to be able to know what some of these classes of drugs are. So in the main ones that Jamie would have covered were things like benzodiazepines. Jamie would have also given you a lecture on antidepressants. So again, what is the definition of an antidepressant? What is an example of an antidepressant, and how does that antidepressant work? So antidepressants, we're using them to alleviate symptoms of depressive illness. A good example of these are things like SSRIs, your TCAs, and your monoamine oxidase inhibitors. But again, what are some examples of those? What are they targeting? How do they work? And again, being able to define what these differences in these drugs are. So again, I'm pretty sure these are no surprise to you because I'm 99% sure that Jamie just reused my slides from last year. So what are the main targets, 4 main targets in the nervous system with drugs? Receptors, ion channels, transporters, enzymes. Okay, so yes, all 4 of those. Okay, so being able to, again, broadly say, what are the targets, and roughly know, when you're talking about, say, for example, benzodiazepines, which class is it actually targeting? Okay. Jamie would have also talked to you about non-classical drugs. So non-classical drugs can also target things like DNA, RNA, okay, but also structural proteins, right? Because proteins do make up ion channels and receptors, but there are also structural proteins in the cells that we can target. What about some examples of ion channels and all these things? Does everyone kind of have a rough idea of some examples of these? So for example, when we're targeting ion channels, what are we targeting? So we're targeting really the opening and closing, the gating mechanism, all right? So something like TTX, right, is targeting the sodium ion channel. Receptors, what are we targeting with receptors? What are we trying to affect? Antagonizing them, yeah. Sorry, someone said something else? With ligands, yeah. So So we are trying to affect specifically the binding of the ligands, right? So just saying ligands wouldn't be enough because ligands can do lots of things, right? The effect of what it's doing. So we can affect receptors by changing how long they're open for, how many times they're open for something like benzodiazepines, for example. That's a key thing to remember about. Enzymes, we're really targeting the synthesis and degradation. So when we talk about monoamine oxidase inhibitors, or something that we talked about in the cannabinoids, about the degradation of the cannabinoids themselves. Transporters, another key one. So transporters, like for example, the serotonin transporter to remove serotonin from the synapse. What effect does that have, and why would you want to do that? Something like the EMT for the cannabinoid system. Why would we want to affect the EMT? Blood-brain barrier, I think, was probably covered very quickly and very simply, but I guess the key thing about blood-brain barrier is, like, why do we actually need the blood-brain barrier? Okay, and like, what is it actually doing to allow substances to come in and out? They're sensitive to things like oxygen, and I think Jamie would have told you about the cell types which form the blood-brain barrier. So very basic about the blood-brain barrier and what it kind of does and what it's sensitive to. Drug dependence, okay? So again, things about definitions, or what are these things? So can anyone define what drug dependence is based on that kind of somewhat blacked out sentence? So a drug is taken due to, compulsion rather than a physiological need? Okay, so yes, it's from compulsion due to physiological need, okay? So that's pretty good. So, and that drug dependence most commonly results from something creating a desire to experience the effect of the drug. Any ideas? Sorry? Abuse? Okay. It's actually repeated administration, right? That's what kind of gives us that dependence. So tolerance, Jamie would have covered tolerance at the start, and I covered a little bit of tolerance in when we talked about LSD. Okay, so when we're talking about tolerance, you kind of need to know, like, when you get tolerance, what is it actually having? What effects does it have when you take the drug again, right? So when you have tolerance, it decreases the pharmacological effect on the drug following repeated administration. So if you were to look at a drug dose curve, if you had tolerance, for example, there'd be a shift, right, in that curve. Cross tolerance is something that's key as well, and again, it's something I touched on when we talked about psychedelics. So when I talked about psychedelics, for example, we talked about how if you take one psychedelic, you can develop tolerance to a completely different type of psychedelic, right? So you can take LSD and develop tolerance to something like peyote because you get this cross tolerance, right? It's not just to the same drug that tolerance is being developed to. Hypnotics, okay? I think Jamie covered that in the anxiolytics lecture. So you need to know, what are hypnotics? What do they actually do? Why would someone want to take a hypnotic? Why is it prescribed? Benzodiazepines is a key one. I've mentioned it a couple of times, so it's probably critical to remember how benzodiazepines work. So with benzodiazepines, we are trying to enhance the GABA-A receptor function in the nervous system. Okay. What else are we trying to? What else about benzodiazepines? What do they do? How do they work? They cause sedation, but in terms of on the receptor, what is it doing to the receptor to have its effect? Yep, so it prolongs the decay of the inhibitory signal, right? Once the GABA-A is activated, so you can see that the decay of the signal compared to control after something like midazolam is longer. Okay, sorry, I don't know your name, but as very correctly mentioned, increase the frequency, right, of the GABA-A receptor opening as well. So again, it's about knowing the different aspects of benzodiazepine. So it's not enough to just know that it prolongs the activation. You need to know that it increases the frequency of the GABA-A receptor opening. Okay, and in some cases, Jamie probably would have also mentioned that it can increase the amplitude of the inhibitory signal in some neural networks. So that's how benzodiazepines affect the receptor and what they're actually doing to neuronal signaling. But you'll also need to know, like, where is the benzodiazepine having an effect, right? Because the GABA-A receptor, there are multiple subunits. There's alpha, beta, gamma, right? And so, for example, for barbiturates are binding to your alpha and beta subunits, but something like benzodiazepines is binding to your alpha and gamma. Okay, so again, barbiturates and benzodiazepines in some cases can have very similar effects, but they bind to different parts of the GABA A receptor, and it's about knowing which one binds to where and which kind of subunit. So I didn't give this lecture, so this is Jamie gave a lecture on SSRIs, right? But this again, I'm kind of reiterating what I said before. You need to know, what is the mechanism of action of SSRIs? What is it actually doing to the neurons? What is it actually doing to the synapse to have its effect? And can you give an example of an SSRI and how that specific SSRI is working? So for example, this is broadly speaking about what SSRIs are and how they function. Jamie gave the example of fluoxetine, right? So fluoxetine is just an SSRI, but it has a kind of better known mechanism. Right? Is that kind of making sense? Again, it's all that theme of like, what are these drugs? Why would we want to use them? How do they work? Can you give an example of how then it's used? Acetylcholinesterase inhibitors. So Jamie would have told you acetylcholine is probably one of the most well-known neurotransmitters. Okay. What is acetylcholinesterase? What does it do in the normal nervous system? And then why would we want to target it? And how does targeting the acetylcholinesterase enzyme change acetylcholine signaling? Right, so if you have acetylcholinesterase inhibitor, what are you doing to the nervous system? What is its mechanism? Correct. You're preventing or you're slowing down at least the degradation of acetylcholine, right? And that means what to acetylcholine? Yeah. So signal persists because the acetylcholine remains in the synapse for longer, right? So it has this effect for longer. Okay, and so then we come to a little bit about what I taught you about, which is endocannabinoids, right? So we talked about cannabinoids. What makes something an endocannabinoid and what makes something, say, a phytocannabinoid. And I told you it was important to remember, generally, what makes up the endocannabinoid system, right? So the endocannabinoid system comprises of what? What components are there to the endocannabinoid system? So we have receptors. We have the transporter. What kind of transporter? What was it called? Right. You need to know that it's called what it was called, because it is transported, but it has a name. Yep, that one. Or EMT for short, but you do need to know its full name. What else? What else do we need in the endocannabinoid system? Right. Think about when you have neurotransmitters, right? We have neurotransmitters, but it's just like endocannabinoids. What is kind of the first step? You have to make it, right? So you have to have you need to have the proteins that actually synthesize the cannabinoids. You have to have the receptors, and you need to have proteins that break them down, right? These are all the components of the endocannabinoid system. And remember when I told you about endocannabinoids, what did I tell you was one of the key things? Well, what are some of the key things that made it different from a neurotransmitter? It's made postsynaptically, it acts presynaptically. Yep, what else? Someone said it. You can say it louder, that's correct. Yeah, I'm looking at you. Yeah, you? Yeah, it's made on demand, right? So it's made on demand, it's not stored in vesicles, right? So that's some of the key differences between that and neurotransmitters. And so, like I told you in the lecture, this is the kind of classical definition of what we define neurotransmitters to be, but it can't be a neurotransmitter because it doesn't show kind of those first two things, right? So again, it's made on demand, it's made in the postsynaptic neuron, not the presynaptic neuron, and it's not stored in vesicles, right? So psychedelics. What are psychedelics also known as? What system does psychedelics work on? I'm hearing serotonin, right? So another name for psychedelics could be, okay, well, what's a common effect of psychedelics? What do they cause? Hallucinations, right? So another term for them are serotonergic hallucinogens. You don't really have to remember, I guess, all the different types of psychedelics, but things like LSD, you'll need to know about how LSD works and what it targets, right? So this is the general kind of like what all psychedelics kind of do. So you kind of need to know what are psychedelics, what are they known as, what are their effects, and like what do they actually act on, right? So yes, they act on the serotonin system, but they don't work on every serotonin receptor, right? And they're not always full agonists for the serotonin receptor. So something like LSD, I showed you how LSD was very similar to the structure of serotonin. And I told you about how it was discovered and what type of receptor that LSD was working on. So it was using selective antagonists. It was shown that LSD is working on what subtype of serotonin receptor? 2A, okay? So it's working on 5H2 receptors, and it's working on 5H2A receptors, and it acts as an agonist or partial agonist for the 5HT2A, okay? You'll need to know then, if it activates that receptor, what that then leads to, okay? So I mentioned that it's a GPCR, and that it was activated through G-alpha-Q signaling or through beta-arrestin pathways. And that 5-HT2A receptors are expressed widely in the brain. So hopefully that kind of makes sense, as might have been the last lecture that we did together. And then just come back to tolerance, right? So one of the key things I told you about LSD, or psychedelics in general, but specifically LSD, is that it develops tolerance, right? So how quickly does tolerance develop to LSD? What is cross-tolerance in the case of psychedelics? And in terms of tolerance to psychedelics and LSD, how does it actually develop? So we know what tolerance is because we just find it from the start, okay? But in the specific case of, for example, LSD, how does that tolerance develop in the nervous system, right? What is happening to the receptors? Where are these receptors located? That all kind of making sense? Yeah. And then lastly, hopefully you enjoyed the lecture I gave you on photoencaging, right? So I told you about the different modalities of photoencaging, and I told you at the start that you need to kind of briefly understand what those modalities were and how they worked, but the one that you really needed to hone in on, the mechanism, was photoencaging. So to remind you, with photoencaging, we have this protective group that's bound to the cage substance through a covalent bond, right? And there's a chromophore that sits on the protective group. And that chromophore is what is absorbing the light, and that breaks the bond between the protective group and the cage group to separate it. And that's how we get the cage group to release to whatever it attaches to. Right. Any questions on photoencaging? Right. And again, I've put here another diagram, if you wanted to go through it again. So again, we have the protective group, and we have the thing that you're interested in releasing, so the cage group. Okay, we can put them on together so we can cage the thing we want to release. Okay, we put on light. The light is absorbed by the chromophore on the protective group, which then breaks them apart. And then the thing that you're interested in uncaging is released. And your protective group actually it's just released. It's still actually floating around. And then once you know what photoencaging does and the mechanism of how it works, you'll need to be able to provide examples of why we would use it in the nervous system, right? And you want to be specific. So, for example, it wouldn't be enough to say that we use it in neuroscience, okay? Because otherwise I wouldn't have wasted my time explaining to you in the experiments of how commonly we use it and why, what are we targeting and how do we do it? Does that make sense? And then, just to finish off, photopharmacology, right? I told you that it's a really cool tool, it's up and coming. But like everything, it has advantages and disadvantages. And you'll need to know what those advantages and disadvantages are, okay? But most of them are pretty simple and it's pretty intuitive, right? So remember, in terms of the disadvantages, I told you like it's great, but in order to do all these things, right, you need to get light into something. And if we're talking about tissue, that can be quite challenging because, for example, the brain, you'd have to literally put in an insert into the brain, right? So it's invasive, you get that formation of scar tissue. Lots of light can lead to actually phototoxicity, right? But then the advantage is that compared to other drugs where we talk about specificity, photopharmacology is great because it has great spatial and temporal resolution, right? And because of that, we don't get as many off-target effects and a lot less side effects as well. Okay, so that's it for the neuro. Does anyone have any questions while I'm here about the neuro? No. Yes?
Regarding the dementia lectures, do we need to know about the pathophysiology of AD and dementia, or just the focus on the treatment for dementia?
You need to understand the pathophysiology of dementia and Alzheimer's in the sense that you know, without knowing it, you need to know what those drugs are actually doing. You know, so you need to know the pathophysiology in the context of how the drug is working.
Okay.
Yeah.
Thank you for clarifying that.
All right. Well, good luck, everybody, and I hope you enjoyed pharmacology this semester.
No MCQs? Never been MCQs?
So there will be some practice questions coming up, I think, for the exam release in the next couple of days. So you'll see that Jamie and I have put together some practice questions for the exam for that.
Thank you. Do you have any questions for the MCQs? Or
Practice MCQs?
yeah.
You might have realized we kind of already have done some practice. I just didn't give you it in MCQ form.
Okay, thank you.
No worries, good luck.
I put this on
All right, yeah, no worries. Let's grab this.
the screen. I'm just going to go over it.
No worries, good luck.
I just realized incidentally. You guys didn't miss any 17 seconds. I just examining code. It's recorded. So.